thank you for joining us in this breast cancer awareness event. And I hope that you will really enjoy the speeches that Dr. Vera Panini and Dr. Alston will be giving tonight. We will be drawing for 2 massages at the end of this, so please stick around until the end, so maybe you'll be the lucky winner of those massages. Now I would like to go ahead and turn it over to Dr. Vera Panini and Dr. Alston. Dr. Vera Panini is our medical director of Riverside Oncology, and Dr. Alston just joined our group for Riverside Medical Group as a family practitioner. So thank you so much for being here, and I'll go ahead and turn the floor over to you.
Hello again, good evening and welcome. Thank you all for braving the adverse weather conditions to make it in tonight. So as was mentioned, this is our presentation for the evening regarding breast health and preventative care. Our goal is to see awareness be on the rise in terms of what you need to know to take the best care of yourself. And so to open up, I'll talk a little bit about why breast cancer awareness is so important. Of course, one reason is because breast cancer, unfortunately, is common. So when we look at cancers that affect women in the United States, breast cancer is number 2 after the different types of skin cancer, so really close to the top of the list. Based on the data that we have currently, it's estimated that a woman living in the United States probably has about a 13% or a 1 in 8 chance of developing breast cancer at some point in her life. And if we look at the laid out numbers for what would be estimated by the end of this year, 287,850 cases of breast cancer in American women this year. So like I was mentioning, very prevalent, and so we want to make sure, again, our patients are empowered to set up appointments with their doctors and know what they need to do to assess their risk and get any necessary screening done. Of course, another reason why it's so important is because, unfortunately, it can have bad outcomes. So when we look at estimates for the number of deaths predicted by the end of this year, it's over 40,000 in the United States. And then the final reason, which I think is a good focus for why we emphasize the importance of screening so much, is because it can improve outcomes. So if there's something going on and we don't know about it, it obviously allows time for things to potentially progress and have more serious implications for any given patient. If we're doing our due diligence to detect things when they are there, and ideally detect them early, then we can get patients set up with our specialists to do everything necessary to improve their outcomes. Moving right along, we'll go ahead and discuss risk factors. And so I've laid out a few here. One we know is age. So as any of us gets older, the risk for a lot of different conditions are going to go up. Breast cancer is one of those. Female gender, which sounds a little bit maybe redundant to say, but there are cases of male breast cancer as well, unfortunately, and we do know that it is much more common in women. Other risk factors include a family history of breast cancer, so if it tends to run in other relatives, especially first-degree relatives such as a mother or a sister, certain genetic inherited genes. So you may have heard of mutations such as like BRCA1, BRCA2. There are others that are known, but having the presence of those can increase the risk as well. Denser breast tissue tends to be a risk factor, as well as something that can make it a little bit more challenging to detect on imaging. And then there are a few different other factors, including having started your menstrual cycle relatively on the younger side, having gone through menopause later in life, not having been pregnant in the past, which I think is proposed to have to deal with interruption of normal menstrual cycles, and the same goes with not having breastfed in the past. And then we'll talk a little bit about this more in detail. Dr. Vera Panini has some excellent slides to talk about specific lifestyle habits that we may have that can increase risk as well. And so those include carrying excess body weight as well as alcohol use. So how do we screen for breast cancer? We know there's risks, we know it's out there. What is our step to check and make sure we're looking for things? Mammograms, I put, ouch. It's no one's favorite thing to do for sure. So why? Why do we have to do that? Why do we have to do an exam that's probably a bit uncomfortable and has to be repeated from time to time? Next, I'm going to kind of go through some questions that I think are very reasonable for patients to ask when they're trying to understand why we're making the recommendations that we are making. So this is an example of saying, well, I get a breast exam in the office when I go see my doctor. Isn't that sufficient? Can I say I'm adequately screened for breast cancer? And the answer to that is not based on the evidence that we have. And so when we look at the data, there wasn't a clear benefit that could be reliably demonstrated in just doing a breast exam alone or even doing the breast exam as an adjunct to a mammogram. Wasn't shown that it would improve outcomes, which again is going to be our goal. We want to help our patients live longer, healthier lives, minimize pain and suffering related to diagnoses. So if it's not offering benefit or a clear improvement in outcome, why would we rely on that alone? And then the other thing that it's been associated with was more what we call false positive results. So a result says, you have this condition, but you actually don't, because tests are gonna have limited degrees of accuracy. So that can lead to things like unnecessary testing, follow-up imaging, biopsies for something that is not cancerous. So then I'm going to go ahead and move along to a follow-up question, because someone might say, well, does that mean I shouldn't get a breast exam? And I just want to be clear, that's not at all what I'm saying. So if there are any breast symptoms that a woman experiences, she should always make an appointment with her doctor to have a breast exam performed. This was mainly just to bring up the concept that it's not a substitute for a mammogram. So yes, if you get breast exams with your doctor, it's good to evaluate any concern that you may have, if it's a lump or a bump or a skin change, but don't count that as a substitute for a mammogram, because we do want to make sure that you're screened adequately. Second one is a similar question. This specifically talks about self-breast exam. So I'm not in the office, I'm at home. I thought, oh, you know, my doctor used to talk to me about this regularly. I'm going to examine myself to see if I notice any changes that are concerning. Isn't that enough? Can I do that in place of a mammograms? And it's a pretty similar answer, so I won't go through all the points from the last slide. But when we talk about, again, what does the evidence show us? Isn't shown to offer benefit, and when we look at considering potential harm that we can cause our patients, again, sometimes we're doing more biopsies because people are finding things that aren't cancerous, and that's putting people through additional procedures, discomfort, cost, and all of that. Again, following the question up, does this mean I shouldn't be checking myself? Absolutely not. And again, I just wanted to throw out some specific examples to show that the tools that we have in terms of self-exams, exams in the office aren't a substitute for mammograms. So if there's anything that's of concern, don't hesitate to bring that up, okay? Jumping back to the initial topic of risk, another good question is, how can I assess my individual risk? How do I know what that is? We saw a bunch of numbers at the beginning. Where do I fall? What is my percentage? And the answer with that is you can ask for help from your doctor. So as part of routine exams, we go through a lot of different aspects of your history. Of course, some things are really easily obtained. We know when we're seeing a woman in clinic, we know your birth date, so we know how old you are. And then the other things we ascertain from questioning. So we'll ask you questions about your family history. We'll ask you about your menstrual history, your pregnancy history, and all of those different things. And then another thing I've been kind of referencing throughout the presentation has been the evidence that's there. And so there are actually models that are available to help us say, let's plug in any individual patient's risk factors and get an approximation of what their risk might be. So this is an example of one tool that we can use. And just to show you kind of exactly what it looks like, the questions here are related to those risk factors that we were talking about on the first slide. So we'll get yes or no answers to some of the questions, specific details, and then it will help us to calculate an approximate risk. That'll break it down into, over the next 5 years, what would we say that that risk is of a woman developing breast cancer? And then over her lifetime, what is the risk for any woman potentially developing breast cancer? Okay. So then we have an approximate risk. We can put someone maybe on the low side, intermediate risk, or high risk. And then how do we use that to guide us? Who should get mammograms based on risk? And so ages 50 to 74, the short answer is everyone. Every woman should get a mammogram to make sure we're doing our due diligence to check, okay? When we look at the evidence, of course there are some things that are pretty straightforward where we have more of a consensus and say, this is the threshold beyond which everyone should be tested. Sometimes we don't get a full agreement upon the experts. This is one of those cases. And so some of the guiding societies actually say, well, if you're 40 and older, you should get a mammogram. So there's a little bit of leeway there. So definitely by age 50, but potentially as early as age 40. So sometimes women may say, well, I want to be more on the cautious side. I'm going to go with the 40-year recommendation. And that's one that I would probably recommend if I were asked about any of my given patients. Sometimes I think having more information is better. But again, there's room for individual choice, of course. And then there are certain special circumstances as well. So we mentioned family history contributing to breast cancer risk. And so if we have someone who has what we would consider a strong family history of breast cancer, meaning a first-degree relative, so mom maybe had breast cancer, maybe mom was diagnosed at age 42, you should actually start your screening 10 years earlier than the age at which that relative was diagnosed. So for a patient whose mother was diagnosed at age 42, we should actually start doing mammograms at age 32. Okay? Moving along with more details of the recommendation. So I know when to start. How often should I do it? And again, there's going to be different circumstances that give us different intervals for the recommendation. So when we look at the recommendations we get, again, from some of the guiding societies, probably every single year. So sometimes we recommend getting a mammogram every single year. There are some of the guidelines that say a more conservative approach could be every other year. So I put at least every other year, but probably every year once you get started getting mammograms. We talked again about risk earlier, and when we look at groups that are going to be more towards intermediate or higher risk compared to the average risk population, you probably want to stick with once a year for sure and no less frequently. And then there are oftentimes additional images that need to be done with that. So if someone falls in a higher risk category, they may even need a breast MRI, which is just a different type of picture essentially to help clarify things. And then it goes on to talk a little bit about that high-risk category, and that's at least once a year, and there are certain cases where it may be a little bit different. Okay, I think that concludes my portion, so I'm going to go ahead and pass things over to Dr. Vera Panini.
That was an excellent presentation. Thank you, Dr. Alston. So as all of you know, this is Breast Cancer Awareness Month. The motive is awareness on the rise. We want to rally and screening everyone. As Dr. Alston importantly mentioned, it's really important to screen women with mammograms. We want to ensure all women have access to the care and support they need, and what we found was that during the pandemic especially, and understandably so, a lot of women fell behind with regards to cancer screening modalities, including mammogram. So when we rise, we rally in screening everyone and support one another. Oops. Okay, so Dr. Luzuriaga is one of our breast imagers. He's from Central Illinois Radiological Associates. Wanted to highlight some of the screening modalities that we offer to patients here at Riverside Medical Center. So as Dr. Alston mentioned, we want to ensure that everyone starting at age 50 definitely gets an annual mammogram. But for a lot of women, it's really important to really start looking at screening at age 40. So a lot of the medical professional societies, including American Society of Clinical Oncology, the American Cancer Institute, or I'm sorry, the American Cancer Society, National Cancer Institute, really recommend starting screening at age 40, but all women should actually have a risk assessment by age 30. So it's really important to see your primary care doctor, because when you do the risk assessment, including utilizing tools like what was found on the National Cancer Institute website with regards to the Gale model, trying to determine a woman's risk based upon her history, her family history, That way, a person can be risk stratified. We know the lifetime risk for any average woman is about 13%. It was previously mentioned in other slides. But there are some women that may be considered higher risk based upon some certain risk factors, and we consider that a lifetime risk greater than 20%. Screening should continue past age 74. There really is no hard stop with regards to stopping and in terms of making recommendations for screening modalities, because if a patient is very fit and we understand that she would benefit from interventions to treat cancer, we should certainly continue to offer these modalities for patients. And as Dr. Alston alluded to, I think it's really important that there's a discussion that's held between women and their primary care provider with regards to the rationale for starting screening. You know, if it's going to be earlier than the age of 40 or at 40, if she really has questions about what's my benefit, what are some of the risks of undergoing screening, you know, in terms of being diagnosed with breast cancer compared to if I started at age 50. But again, most medical societies would recommend starting screening mammograms at the age of 40. I keep hitting the wrong one, sorry. It won't advance for me. Oh, there we go. So screening mammography will be offered at multiple different areas. So we have it offered at the main campus at the Pavilion, here in the Bourbonnais campus, Coal City, and it's anticipated in the summer of 2023 that it would also be offered at Watseka. We have 3D mammography or tomosynthesis available at all of the sites, which is a very important advancement for the services we can offer to patients. I actually took it for granted that 3D tomosynthesis was offered at all places, and I went to a recent breast cancer conference, and conventional mammography is offered everywhere, but we really have state-of-the-art breast imaging. So in terms of asking questions about whole breast screening ultrasound, we get this question a lot. Well, in addition to screening mammogram, would I be indicated for an ultrasound as well? Ultrasound should be considered a supplemental imaging study for women who have dense breast and are at average risk. And it's also used as a supplement for high-risk screening for patients who would be eligible for a breast MRI but are unable to tolerate it. So whole breast screening ultrasound, we have a handheld ultrasound at the main campus. We have an automated breast ultrasound at the Bourbonnais Plaza. And currently, there are protocols in place that the radiologist will follow for women who have dense breast tissue. They will notify the ordering provider with regards to which patients would be indicated for the ultrasound in addition to the mammogram. And so women will ask, well, I received information with regards to ultrasound. Should I be getting one every single time I go in? And actually, that is a decision that is made between the radiologist who interprets the imaging as well as conferring with the referring provider. So there's a lot of thought that goes behind the whole situation. When we talk about breast cancer screening for those women who are higher than average risk, we want to take into account the issues that were mentioned before. So annual mammogram can start at age 30. A lot of this is based upon potential hereditary breast cancer syndromes or genes that were inherited. Those who are known to be carriers of these pathogenic genes and have untested first-degree relatives, they would be indicated for or risk stratified as being higher than average. If the calculated lifetime risk utilizing some of these risk assessment tools like the Gale Model 2 is determined at greater than 20%. Or if a woman has a history of chest irradiation, those are things that we want to, those are individuals that we want to stratify as higher than average risk. Again, these are reiterating some of these higher risk categories, and then annually beginning around age 25 to 30, really supplementing mammogram with screening MRI. Dense breast tissue can also be another risk factor, and certainly being diagnosed with breast cancer before the age of 50. We would also consider breast MRI in addition to mammogram for those individuals who are diagnosed with lobular carcinoma in situ, which we know is a breast cancer precursor, high-risk lesion, or evidence of atypia on a prior biopsy. We also want to make sure that for those individuals who are transgender patients, that we do start annual screening at age 40. So for those who are assigned female at birth and then make the transition to male, the male gender and have not had a mastectomy, we want to ensure that we continue to provide cancer screening services for these individuals. For those trans feminine patients who are assigned male gender at birth and make the transition to female, we want to make sure that those who have used hormones for greater than 5 years, we also want to ensure that we screen them appropriately for breast cancer, because men develop breast cancer as well. Those who are assigned male gender at birth also have that risk, especially if they've been exposed to hormones. So we talked a lot about why screening is important, but what else can we do to reduce the risk of developing breast cancer? And these are issues that are very near and dear to my heart, because as I joke around with my colleagues at work, if we found a way to stop people from having breast cancer, I'll go to culinary school. So cardiovascular disease and breast cancer have shared and separate risk factors, and you may ask, well, why in the world is an oncologist talking about cardiovascular disease? And as I think you can see here from this Venn diagram, there are known separate issues that increase the risk for cardiovascular disease and definitely for breast cancer, but here they overlap. And I think most people are pretty familiar with the risk factors for cardiovascular disease, and it actually is the #1 cause of mortality for women. So I want to make sure that I emphasize, if we address the overall health and try to optimize control of the things that are within our control, you can actually impact the risk of developing this disease. No one's ever going to use the word prevent, but what can we do to reduce the risk? And that's what I really wanted to highlight. So it's really interesting, because there are these initiatives across the country now recognizing the overlap between what cardiology does, what primary care does, and what oncology does. Because as I mentioned, we've got these common risk factors for both breast cancer as well as cardiovascular disease. What we also find is that some of these very same risk factors and comorbidities can actually impact the types of treatments that we are needing to give in the oncology clinic when a woman is diagnosed. So again, if we're able to optimize a woman's health overall from the get-go, you have better outcomes from the very beginning. So with regards to obesity, there's at least a 25% risk of developing breast cancer. Diabetes, 20% risk. Here I've mentioned some of the potential mechanisms. Elevated cholesterol and triglycerides, there's at least a 9% risk. Hypertension, 15% risk. Atrial fibrillation, 35% increased risk. And they attribute that to reactive oxygen species that can be identified in these patients. I borrowed this slide from Dr. Akhtar, who is one of the cardiologists up at Northwestern. She did a beautiful talk on cardio-oncology issues, because all of these centers of excellence are starting to recognize what can we do to optimize the outcomes for our patients that need to undergo oncology treatment, but then thinking even further down the line, what can we do to intervene and intercept even before these women develop breast cancer? So here I hope, this slide, again, borrowed from Dr. Akhtar, helps understand the intersection of these risk factors that can increase the risk for both breast cancer and heart failure, and to allow for providers as well as for people in the community to understand how important it is for all of these different spheres, how they all relate to one another, how they can all lead to disease, and how ultimately all of this comes into interplay for development of both breast cancer and heart failure for women in our community. Here's just another graphic that looks at some of the things that we have, our Western diet with tons of processed foods, lots of simple sugars, carbohydrates, high in saturated fats. That not only increases the risk for cardiovascular disease, but also for breast cancer. We know that market intake of red and processed meat can certainly contribute to that, a sedentary lifestyle, smoking, and as was mentioned earlier, the early onset of menarche, and then hormone replacement therapy can actually contribute to that too. If we look at the two areas where both of them are decreased, it's really optimizing your nutrition and then increasing your physical activity. So free, very difficult to follow sometimes, but something that we should all remind ourselves of. One thing I'm really proud of is that Riverside has supported our initiative to formalize a cardio-oncology clinic so that way our individuals who are diagnosed with breast cancer are able to get optimal cardiology care, looking at some of the specific treatments that we give that may be affecting a woman as a cancer survivor. This is being spearheaded by Dr. Na Win, Dr. Siban Liu, and so I'm very grateful for their initiatives after I started this initiative with Dr. Lynn Brown. So Really want to make sure that we emphasize the importance of heart health because, again, the intersection with regards to breast cancer risk. That being said, it cannot be emphasized enough the importance of the primary care providers. When patients go through our clinic, we always make sure that they have the opportunity to meet with our nurse practitioners for their survivorship visit, and we always make sure that we send a summary of a person's time through the time of diagnosis, time through treatment, and beyond to their primary care to their primary care physician. This is from the American Family Physician Medical Journal, and it highlights the things that we really talk about in oncology clinic. And so it's very nice to see this multidisciplinary approach to taking care of individuals who have been diagnosed with breast cancer, moving forward with their primary care provider and the things that they need to be monitoring for. So I can't emphasize enough the need for risk assessment with a primary care provider because these individuals are the ones that a young person who doesn't have any medical issues may see for a long, long time. That might be the only doctor or healthcare provider they may see. And then as certain medical issues may develop along and other subspecialists get involved in their care, that primary care provider is actually the quarterback, if you will, the captain of their entire team to be able to look after things. So I can't emphasize enough the need to be connected to your primary care provider about screening, about risk reduction, smoking, obesity, sun exposure, things that we know can increase the risk for cancer in general. So again, seeing him or her is really, really important. Thank you. Does anyone have any questions about anything? Like literally anything. It's a really small group, so. Yes?
I know they say that you should stop having mammograms around 74 if you've already had breast cancer. Is it wise to continue after that age?
So I'm going to repeat it because this is being recorded. So the question was, some of the recommendations from certain societies have recommended stopping screening mammograms at age 74, and is that something that you should be doing? I don't know if you noticed on one of the slides, but we're actually trying to encourage women beyond the age of 74 and 75 and beyond to continue getting their screening mammograms if they're fit enough to be able to do it. So the rationale for doing a screening intervention is to identify something early so we can treat early stage disease. If a person is very frail and probably has too many medical issues to be able to undergo the necessary diagnostics like biopsy, surgery, and then everything else that potentially can come after that, it really should be a discussion with that patient and her primary care provider about what utility would there be in undergoing a screening test if I'm unable to move forward if they find something. So that's an excellent question. Yes.
I had read and heard that there's a lot of advancements with treatment of breast cancer, and that chemotherapy is not always being used, but sometimes they go directly to radiation for certain types of breast cancer. If that's changing, ever changing.
So the question was that you've heard that chemotherapy is not necessarily the first line that's used to treat breast cancer, and that there are lots of therapies that are advancing in it. And then, I'm sorry, what was that with regards to the radiation portion?
That maybe they go to radiation rather than chemotherapy.
That they go to radiation rather than chemo. So it is true that there are a lot of advancements in the treatment of breast cancer. Chemotherapy has its role, and we certainly are doing our best to treat women with curative intent when they're diagnosed with stage 3, 2, and 1. There are small molecule inhibitors and other targeted agents that we're now able to utilize for those individuals that meet that criteria. So a lot of the small molecule inhibitors are used in the metastatic disease setting, which if we're able to go ahead and use those, then we would prefer to use that other than conventional chemotherapy. So that part is true. For women that are getting treated with curative intent, chemotherapy still has its role, especially for those individuals that have HER2-positive disease, because we have to use anti-HER2 targeted agents like trastuzumab and pertuzumab in combination with chemotherapy. For those women that when we talk about risk stratification, for women that do not seem to need adjuvant chemotherapy and we're able to safely say, okay, she's a really low-risk individual, those women can move forward even in some node-positive postmenopausal women, we're able to safely eliminate the utilization of chemotherapy and have them move on from surgery to radiation, and then after that undergo endocrine therapy. For women that are premenopausal, or particularly if they have this molecular assay that's called Oncotype DX that risk stratifies them into a high-risk category, those women would benefit from adjuvant chemotherapy to reduce the potential for future breast cancer. So. Like literally any other question.
So if you've gone through breast cancer and breast cancer treatment, does that kind of qualify you to get the 3D mammogram, or it would be nice if that replaced the regular mammogram?
So the question was, if you've been diagnosed with breast cancer, would that be an indication for the 3D mammogram, or can you get, or do you just get the regular mammogram? So great question. So actually, every woman who undergoes a mammogram actually undergoes the 3D tomosynthesis, even as a screening modality. There is a difference in the imaging that is done between the screening mammogram and the diagnostic mammogram, and the utilization of a breast MRI, women have to meet certain criteria. Years ago, like in the early, the mid-2000s, probably like 2005, 2006, there was a big paper that was published in the New England Journal of Medicine talking about the utilization of breast MRI, and so everyone was doing a breast MRI in addition to a mammogram, and what we found was that it actually caused a lot of false positives. So women were being put through, because it's a very sensitive imaging study, and so women were undergoing unnecessary biopsies. We found an increased rate of women choosing mastectomy, which for some women is indicated. It really, really is, and that's a woman's choice as well, but I think a lot of what people were understanding was that there was a lot of fear that was being generated by a very sensitive test, and we have to be very careful about the utility of studies that may lead to a lot of false positives, as Dr. Alston mentioned before. It's a lot of anxiety, it's a lot of unnecessary cost. And so the utilization of screening MR in addition to the mammogram, we want to make sure that we're being judicious, and so the categories of those women have been defined: higher than 20% lifetime risk, those women who have a known hereditary cancer syndrome and are genetically predisposed to developing breast cancer. So.
It'd just be nice if they came up with something other than mammogram.
Yes, the comment was it would be nice if they came up with something better than mammogram, which I can understand. I will say this though, I mean, as a screening modality, from a physician standpoint, it's really easy because the tissue's on the outside of the body. So actually, the mammogram is a really wonderful screening test. I mean, from a screening perspective, it really is the only tool that has helped, decrease mortality and identified early stage disease. But I hear you, because yes, they are not fun. So. Any other questions? Yeah.
Are you seeing, like, people that have already been diagnosed and treated, like past maybe the 5-year, or whatever, are you seeing an increase? Are you seeing, like, what percentage of people get diagnosed again with the breast cancer? Is there any?
So that's a good question. So the question was, for women who've been treated with curative intent beyond 5 years, what percentage do we see coming back with recurrent disease? And that's actually a really difficult question to answer. I would have to go to our tumor registrar to see. When women reach that 5-year mark and they are completely done with adjuvant endocrine therapy, we do give patients the option to go ahead and be released back to primary care, so that way they can continue on. As I mentioned, there's this continuum of care where women will transition from cancer patient with an active diagnosis to cancer survivor. Actually, cancer survivors from time of diagnosis, so technically. But when that woman goes through a transition, she always has the option to come back to the oncology clinic, but because we really want to focus on optimizing overall health, it really is important to go back to the primary care physician at that point if there isn't something active to treat. That being said, for some women that are higher risk and remain on endocrine therapy for a long period of time, those women will continue in both clinics, both medicine as well as oncology. As far as what percentage we're seeing, it's really hard, because I know in my day-to-day, my personal bias is like sort of skewed, because I tend to see the Patients of higher acuity, and my nurse practitioners will see those individuals that are stable and doing really, really well. So whenever patients come into my clinic and they're doing really, really well, it's really nice because I tend to see the sicker of the sickest. So.
Do you ever encourage women to go past the 5 years, something that's resolved in the 5-year pill, or is it just 5 years and it's really all they need to be on?
So the question was, do I ever encourage women to take the endocrine therapy beyond 5 years? And the thing is, if they're indicated for it, if they're higher risk, like they have multiple lymph nodes involved, and we know they had a strongly hormone receptor positive tumor, then I would encourage them to continue taking the endocrine therapy so they can suppress the production of estrogen. That being said, it's a personal discussion with a woman to make sure that she's able to tolerate it, that her bone health can tolerate it. We do know that there are other side effects. It can affect heart health and things like that. So, and quality of life is a very important thing as well. So we always have a personal discussion. There is a risk assessment tool looking at the potential benefit of going beyond 5 years. It's called the Breast Cancer Index. Sometimes that can be used as well to help guide medical decision making, but ultimately it's really about having that discussion with the patient about whether or not she would be able to tolerate it and how she feels about coming off her endocrine therapy after 5 years. So.
These are all questions I was going to ask you. My next business.
Awesome, I love it.
What is the rate of incident in the Kankakee area? Do you know, compared to like the national average or?
So the question was, what is the incidence of breast cancer in Kankakee County compared to everywhere else? And I actually don't know that number off the top of my head. I would have to go to our tumor registrar.
Is it considered high for this area though, do you know?
I don't know. I don't know. Yeah. Yeah. But for everyone out there, just do what you can to take control of the things within your control. We got to optimize nutrition, increase physical activity, get screened, continue following up with your primary care physician, and maybe for the next talk, we'll go ahead and make sure that we address those numbers, and so that way we'll have that for you, and we can, make an assessment and compare ourselves to the national average, because it would be really nice to see if we're doing better.
Unless there are any other follow-up questions, that'll conclude for the evening. Of course, feel free to grab any additional refreshments or snacks, and thank you again for coming out.